Good morning everyone, and thanks very much for inviting me here this morning. I'm very excited at this next phase in rolling out the health benefits of safe work to GPs in Victoria, and I see you guys as integral to delivering that message. Just to give you a bit of background, the health benefits of safe work is an initiative that saw its beginnings back in the UK back in about 2006, when the British government, concerned with the number of people who may be in the workforce but were not due to disability and ill health, tried to get some handle on how big that problem was. And they engaged Mr. Gordon Waddell and Dr. Kim Burton, an orthopaedic surgeon and an epidemiologist, to review the literature as it was at that time over the last 30 or 40 years up to 2006 to see what they could gather and find out about what the health benefits of work were, or to answer the question that is the title of their book, and you can't see it all that well, but it says, "Is work good for your health and well-being?" So the title of the book was not "Work is good for your health and well-being." The title of the book was a question, and they set about answering that. And there are over 400 selected references in there, and they're selected for their rigour and their comprehensiveness. And once this came out, it was disseminated around England and around the world. And in Australia, the Royal Australian College of Physicians, and in particular my faculty, the Faculty of Occupational and Environmental Medicine, took it up. And they produced a position statement, that document there, which I think is in the pack, or it's certainly in the online resources. And this applied those principles to what was going on in Australia and New Zealand. And having reviewed all of the available literature, the faculty decided that work is generally good for health and well-being, and more importantly, long-term work absence has a negative impact on health and well-being. And that's particularly striking. And it's not just in the areas that you might think about, that people put on weight and they don't do as much exercise and so on and so forth. It impacts cardiovascular health, it impacts respiratory health, it impacts musculoskeletal health, endocrine health, it impacts psychological health, particularly psychological health. The rate of suicide, unfortunately, in people who are out of work is much higher than people who are in work, it was found. And it not only affects the person who's not in work, it impacts their family quite adversely, and particularly the children of those people. The position statement also says that good outcomes are more likely when individuals understand the health benefits of work and they are empowered to take responsibility about their own situation. So in other words, getting them off the conveyor belt and getting them to take responsibility for their own situation really, for people who are empowered, helps. And one of the key people in that situation and helping people take responsibility for their own situation are health professionals, and in particular general practitioners. In Australia, there is no one more better placed than to help their patient take responsibility for their situation than that person's GP. And so the position statement says that health professionals, particularly doctors, exert significant influence on work absence and work disability, particularly in relation to medical sickness certification practices. And what we're about here today is helping GPs make that a positive experience for them and also for their patients. We know that certification for a lot of GPs is a very negative practice to go through. They find it difficult. There are lots of influences that they have on them to write certificates in certain ways for their patients. And some of those influences are not to do with the injury or the condition itself, but other psychosocial impacts that come to bear And we know that from surveys that we've done on GPs in Victoria. The other thing that we know is that inappropriate certification can actually iatrogenically, that means caused by the doctor, cause ill health on its own. So if you go to your doctor and your doctor says you're unfit for work, you think, I'm unfit for work. But if that continues to happen time and time again, you start to get a mindset that I'm not well. My doctor thinks I'm not well, I'm not fit for work. And over time, just the mere fact of a doctor certifying incapacity can make a person think they're sick and not fit for work. So it can have a negative impact, and what we're trying to do is to turn that around so that certification is a positive experience both for the GP and their patient. Why are we concerned? We're concerned because a significant number of people in Victoria who are injured at work or who are injured on our roads do not return to work. And the longer someone's away from work, the more likely they are not to return. And I thought when I first heard that statement way back in the 1980s that that was to do with the seriousness of the injury. If someone was really badly knocked up in a motor car accident with multiple fractures, closed head injury and so forth, yeah, it's unlikely that person would return to work. But these figures relate to all injuries, and we know that the longer a person is away from work, the less likely they are to return, no matter what the injury is. Just the mere fact of being away from work is the thing that appears to keep you away from work longer. So getting someone back to work as early as is medically feasible and possible is what we're on about, because coming back to work early helps recovery. These are the statistics from WorkSafe for the year ending the 31st of October 2011. And what this shows is the percentage of injured workers claims that exceed 2 years. So in other words, they're still receiving benefits from WorkSafe after 2 years, and it's the percentage of people who are out here at 2 years still getting benefits, that is at 104 weeks. If they've been away from work for 4 weeks, 13 weeks, 26, 52 and 78. So you can see if someone's away from work for 4 weeks, the chances of them being away from work at 2 years is about 10%. If someone's away from work, certified unfit for work for 3 months, which is 13 weeks, the chances of them being away from work at 2 years rise up to 25%, 1 in 4. And at 26 weeks, it's over 40%. And if they're away from work at the end of the year, there's a 65% chance they're going to be away from work at the end of the following year. So the longer someone's away from work, the more likely they are to be away from work for longer. And we don't have figures that go beyond that yet. And if you think that's bad enough, have a look at TAC. Someone who's injured on the road, if they're away from work for 3 months, there's a 31% chance that they're not going to get back to work in 2 years. And, at 18 months. And a 50% chance at 6 months. Now, there are a couple of differences between WorkSafe and TAC in regards to return to work. In the WorkSafe environment, employers are obligated to provide suitable duties. They have to under the law, under the Act. But with TAC, they don't. So if someone's injured on the road, an employer is not obligated to provide suitable duties. And this may explain some of that. The other thing is, of course, that motor accident injuries are often more severe than work-related injuries, and that may have some impact on that graph as well. But still, the longer someone's away from work, the less likely they are to return. So, based on that position statement, the College of Physicians partnered with the Royal Australian College of General Practitioners to produce this document called The Role of GPs in Realising the Health Benefits of Work. And this is signed off by the President of the College of GPs and I think by the President of the Faculty of Occupational Medicine. And it sets out on one page of this document the evidence base, which I've been just touching base with you about this morning, and on the other side some ways that GPs may actually help their patients. So the evidence base is that work is an important part of rehabilitation and that it is a therapeutic intervention. It is as therapeutic as writing a prescription for something. That's something that one of the messages I really do want you to get across to the GPs that you're seeing. Certification is therapeutic, one way or the other. It can be positive or it can be negative. And waiting for someone to recover actually delays their recovery. If you could help someone back to work and back to activity earlier, then that will help them recover earlier. And we know that from certain studies that have been done. And staying away from work, we know, leads to poorer health. We know that if an employer is supportive, then someone will get back to work more quickly and it will help recovery. So how are my colleagues, the GPs, going to help their patients return to work? Well, recommending a gradual increase in activity is one way to start. You know, you don't throw someone in the deep end of the pool, you put them in the shallow end and help them, you know, walk down the deep end as they recover. So a graduated increase in activity is always a good idea. Setting a timetable and setting expectations, and you do that at the first consultation. If someone comes to see you or see a GP at the first consultation after an injury, the GP should be talking to their patient about, well, what are you going to do at work? When do you think that you could go back to work? I think you probably need, you might need a couple of days off to just recover from the injury, but after that we should be thinking about going back to doing something. Talking to the employer, preferably while the patient is there, especially about work duties, is important. And we know that if a doctor does that, the likelihood of someone going back to work is twice as likely to get them back to work more quickly than a comparison group that was done in one study. Doctors don't particularly like picking up the phone and talking to employers. They're too busy, they're on 10-minute appointments and that sort of stuff, and it's difficult for a GP to do that, and I acknowledge that. But if a GP does do that, they are significantly going to help their patient get back to work. Working with the patient to identify obstacles that might prevent them from going back to work and working through solutions. Being clear about what we can do as doctors and what we can't do. Increasingly, I find community thinks that we as doctors can do everything. There's a cure for everything and I should be able to get better. There's a magic injection for this, that and the other thing, and we know that that's not the case. And then identifying possible sources of support. So building on the little card, this is the pathway for GPs to help their patients return to work. It says compensable patients return to work, but really it's for all patients. It doesn't matter whether it's a compensable injury or not. This is a pathway that GPs can adopt for all their patients when you're thinking about getting people back to work. And the first thing is, what can the person do? For far too long we've been concentrating on what they can't do. We always put restrictions on certificates and so on and so forth. We don't ever really concentrate on what someone can do. And from the work that was done in the UK 5, 6, 7, 8 years ago now, led by Dame Carol Black over there, she changed the certificate in the UK from a certificate of disability to what she called a fit note. And that turned the emphasis around from what someone can't do to what they can do. And we've adopted that here in Victoria. So the emphasis is what the patient can do. And that's a discussion that's got to occur between the GP and the patient. It's not just something that has to be dreamt up, it has to be practical. And the GP should be talking to their patient about the health benefits of getting back to work. Because it's part of getting back to life. It's getting back to what you're really doing. And then the GP's responsibility is to provide a timeline for that. And that's based on the diagnosis, the severity of the injury or whatever it is, maybe side effects of medications and so forth, all wrapped up into that diagnosis and prognosis. And then the prognosis ties into getting someone back to work. So that's the timeline. And then certifying capacity. In a compensable situation, this is really important. And we're going to talk about that in a minute. And then lastly, reviewing the progress and considering if other referrals or other support services are necessary. And then on the next, that may be the first consultation, and then on the next consultation, the review goes up the front. You review what's happened, then you assess and go through that whole process again. So that's going to be the sort of the process that we're going to be rolling out to GPs. And to help them do that, we've actually designed a new certificate. The certificate of capacity, as it's called, the current one's been around for, my guess is about 15 years, and it hasn't changed in 15 years. And there is a certificate for WorkSafe, and there are 2 separate certificates for TAC. And we've round all of those up into one certificate now. We've also stripped out of the certificate a lot of the non-medical stuff that's in the current certificate to do with things like liability determination and that sort of stuff. That's not for doctors. That's not a medical decision. That's a claims management decision somewhere else. What we want to do is to make this certificate simpler for GPs to fill in, but also concentrate on what their patient can do so that the certification is more accurate. So that's sort of what it looks like. You can see there are a lot of boxes there. There's identification material up the top, a box here to put in the diagnosis, and then here are tick boxes, which I'll show you in more detail in a minute, about what the patient can do, what they can do in a modified sense and what they can't do over here, and a big box to actually explain what's going on here. That's for physical injuries, this is for psychological injuries, and there are some other boxes down here that the GP can fill in if there's extra information he wants to convey. Remember that a certificate in a compensation sense is a tool of communication between the doctor, the employer, and the claims manager. So when the doctor fills this in, not only is he telling his patient what he thinks he or she can or can't do, but he's also telling all these other people as well. And the back of it, it's a 2-page A4 document. That's when it's printed, but most of this will be on computer programs. There's a certification area at the top where the certifying practitioner certifies what someone can do, and then a sign-off and a declaration by the patient. So it is designed to improve information exchange and put a positive focus on what the injured worker, which is a term that WorkSafe uses for patients, injured worker can do. TAC uses the word client. As a doctor, I prefer the word patient, but I'm old-fashioned. And it's also to support the conversation between GPs and their patients about returning to safe and sustainable work. And if this certificate is used properly, it does actually stimulate the conversation and reducing the number of forms, as I said previously, and aligning the workflow of a consultation into software. So the bit that actually stimulates the conversation is this tick box area where it's number 3, the area on the certificate where it says capacity assessment. And I see this as an opportunity for the GP to have the discussion with their patient along the lines of what we've talked about previously about what you can and can't do. Can you sit? Yes, I can sit. Say that someone had a back injury, for instance. They've strained their back. They can sit, but they might not be able to sit for a long time. So I might tick that middle box, tick with modifications, sit with modifications. Stand and walk? Yeah, you can stand and walk, but you wouldn't want to be standing up at a bench all day with a sore back, so you might actually want to sit and stand intermittently. So that may be with modifications. Bending, I don't particularly want to bend if I've got a sore back, so maybe I might certify that my patient can't bend for the time being, And squatting, you should be able to squat and kneel, reaching above shoulder height. So these things you could tick as the person could do down here. Use injured arm or hand, well that's not applicable. Lifting, well manual handling may be restricted in someone with a sore back, so you may put modifications on that. Neck movement may not be restricted, so you tick can. So you'll have a number of things that the person can do, a number of things that the person can do with modifications, and a number of things that the person can't do at all. That's for a physical injury. And then for the things that I've ticked with modification, I just might put an explanation over here, able to sit, stand, move around as he wishes. Maximum manual handling of, the typical one is 5 kilograms or 10 kilograms, something like that over here. So that's the opportunity for the GP to explain what he means by modifications. And down here, if it's a psychological injury, is attention or concentration affected or not affected? Is memory affected or not affected? And is judgment affected or not affected? Because that can be important in many, many jobs. And that can be expanded here. And that might be from the injury, or it might be that someone's taking Panadeine Forte or Endone or something for pain, and that may affect some of these cognitive and mental health functions down there. And once that's filled out, then the GP has an idea of what someone can and can't do. And based on what someone can and can't do, you can certify, the GP can certify if he could do everything and it was really just a simple little injury, then you could certify that they're fit for their work, that they don't have any restrictions. The next box is certifying a capacity for suitable employment, and that implies that someone does have partial capacity but not full capacity. And that would come from that tick box before where there were a number of modifications or can't do boxes, but someone may have a capacity for restricted duties, is the old terms that we used. And if someone really was really injured and couldn't work at all, then no capacity to work in that last box. We have deliberately made it a little bit more difficult for a GP to certify total incapacity. We know from the certificates that we've reviewed over the last couple of years, and we know that there are nearly 300,000 certificates issued every year, that more than 50% of them are issued for total incapacity. And reviewing a sample of those and looking at what the diagnosis was, we think that a large number of those certificates of total incapacity don't really come from the injury. With that injury, it doesn't really warrant total incapacity. So we are trying to get GPs to certify what someone can do rather than write them off for work completely. Because it's not a GP's role to figure out what someone can do at work. They don't have to go and look for the jobs at work. That's the employer's responsibility. A GP's role is to assess what their patient can and can't do. Capacity. If a GP certifies clearly and honestly what someone can and can't do, that's the end of their responsibility. What happens next is that certificate goes to the employer. The employer says, Dr. Slee has certified Mr. Jones as can sit, stand, move around as he wishes and got a manual handling restriction of 10 kilograms. There might be some, I think there's some safety procedures that we need written up in the office for the next few days, and we can provide those sorts of duties. But that's not for the doctor, that's for the employer to sort out. What the employer will do then, they'll send what's called a return to work arrangement form to the GP, and the GP looks at the duties which are described and see if they match the restrictions. And and you do that with the patient in front of you, and if everyone agrees, everyone ticks off and the patient goes back to work. But the patient cannot go back to work if there is a certificate certifying total incapacity. So what we really want is the GP to say what a person can and can't do and then certify suitable employment. Because someone really has to be pretty badly injured to be totally incapacitated. And then, estimated time frame to return to work. If a GP fills this out, this will give people, the claims managers, the employer, those sorts of people, an idea about what other things they have to put into place to support the person or replace them at work or do something like that, considering how long someone's going to be away from work. So you can see that the language focuses on capacity versus restrictions, and capacity for employment replaces modified and alternative duties, which is on the current form. And providing an estimated time to work assists planning for return to safe work. So that's the sort of the high level overview of the certificate. But you're going to hear a little bit more about the certificate in detail in a minute. There are some resources, there are some pretty good resources out there to help GPs have the conversation, because as I said earlier, it can be difficult to have that conversation, particularly with someone who's sort of a bit reluctant about going back to work. I don't want to go back to work, I might aggravate my back doc if I go back to work, that sort of thing. So the GP has to be reassuring and be able to have that conversation. And there are a number of short videos that we've done so that the GP can see how that conversation might take place. And there are now in production a couple of longer videos to show how a GP may be able to progress that conversation with a patient that's not quite so accepting of that message in the first place. So they're out there, and there are lots of other resources there that are in the pack and online.